I first discovered my melanoma on the back of my leg when I was coming home from holiday. So I just went to the doctor for something else actually, and I said, can you just look at this mole also? And he said, if you think it had changed, then I will remove it. And then in a couple of weeks they called me and told me that it was a malignant melanoma. And I think it was at that time I was referred to a specialist in dermatology. And he discovered one on my arm also, so I had to remove. In my work, I've seen the worst case of malignant melanoma with metastatic, because this is what I work with. And I was pregnant when I did the 2 first malignant melanomas, and it took some time before my shoulder came down and I tried to live normally. The first years were a lot of stress about these melanomas. I was super careful in the sun. My husband tried to carry an umbrella over me in the beach, and I was a lot afraid.
Melanoma is a cancer that originates in the melanocyte. So that's where the name comes from. And we have melanocytes in the skin, but also in the eye and in the mucosa of the intestine. When it comes to hereditary melanoma, and the genes we are talking about, CDKN2A and CDK4, that's mainly melanoma of the skin. They are mainly associated with a high risk of cutaneous melanoma. There are also other types of cancer that has sporadically been reported. Pancreatic cancer is part of the cancer spectrum, and among them is leukemia and breast cancer, but the evidence is not there yet.
I started working in the oncology department around year 2000. And at that time, nobody wanted to work with melanoma because it was so sad. The patients came in, got a couple of courses with chemotherapy, and they just died. And this has completely changed now. After 2010, 2015, immunotherapy came in, And now it's really fun to work with melanoma because we can see these nice responses and even good tolerability and good quality of life in the patients, even if they have a lethal disease. But remember, it's still a serious disease. Most of the cases are sporadic, so not hereditary. We have a few, but they are very rare. But we know the families that have familial melanoma, and we follow them closely, and these patients are followed especially close because they have even higher risk than the general population.
When I had my first melanoma in January 2012, I removed one, and right after, 3 months after, I take another one. And then I asked the dermatologist if there was any kind of test we could do to see if it's something in the family, because my father had it and his father had it. And he said he had to refer me to genetics. So I had an appointment with them, and from there I've been told that we were in this familial malignant melanoma.
There are several genes involved in familial aggregation of melanoma, and some of them give also risk of other cancers. But for cutaneous melanoma, CDKN2A is the main gene, and CDK4 is also a gene that plays a significant role. If you have inherited the variant in CDKN2A or CDK4, you have a high lifetime risk of melanoma. It varies between different populations, and it also varies between people with different skin types. But it has been reported in European population to be 70% risk of melanoma by the age of 70. So in your family, we know that you belong here. There is a pathogenic variant in the CDKN2A gene in your family. And we know that you are at a 50% risk of having inherited that variant. So if you have inherited this variant in CDKN2A, what that means is that you will be at a high risk of getting melanoma. There is also, especially in some families, we don't see it a lot in your family, but some families can also have a higher risk of pancreatic cancer. The risk of pancreatic cancer has been estimated to almost 20% by the age of 70, while for the Swedish and the American population, a recent publication estimated it to be around 8%.
I have 2 sisters and 1 brother. 2 of them are positive, and my one sister, she doesn't have it. And this is all our children. Also Birgit, Nina, Birgit, Nina, Nina. Okay. That's 2 stykker. Yeah, this is my grandfather who also had malignant melanoma. It's him. Han hadde og kreft.
Ja, du vet, når jeg vokste opp, så husker jeg min far, han hadde noen stygge føflekker i ansiktet, ikke en av sidene da. Og de tok han vekk. Men det skjedde ikke noe da. Nei, vet, den gangen, dette var jo tenker meg om, i begynnelsen av 70-årene, og vet, de var ikke kommet så langt, så jeg vet ikke, han hadde gjerne den genfeilen, men det vet vi ikke. Jeg var cirka 30 år når jeg oppdaget den første. Da var det en nabo her oppe som sa til meg, du må gå til doktor med den føflekken jeg hadde. Jeg hadde en like stor som negl. Og etter det så har jo jeg tatt sikkert 10 stykker, men de andre senere har jo vært veldig små og veldig lite kreft i, sånn at men de har jo tatt litt mer kjøtt hver gang, ikke hver gang, men på en del av de. 30-40% av de.
I'm not quite sure what I said. Maybe did you get a call from me?
I can't remember.
No, I cannot remember either.
We have to take the test.
Yeah.
That's what told us. We have to all take the test.
Yeah.
But I remember you have to take it, and we got to get a letter, and it's important for us to take it. That I remember.
I remember when I decided to take a test, I was working outside in their new house, and I was you had a daughter. That's why. If not, I don't think I have been up there. I guess if I know myself.
Ja, negativt da det jo
De som ikke har det.
4, 5, 6. Det de som negativ.
Ja, men, ja da.
Og det positive da, så det at da 24.
Nei, ikke 30, vet du.
Nei, ikke i familien, nei.
15 som ikke har det da, og så det 6 som har det, kan du si.
Ja.
So there are some things you can look for when to suspect hereditary melanoma. And that, of course, is if you have multiple cases of melanoma in one family. Could also be multiple cases of melanoma in one patient. But when it comes to like referral criteria or criteria for germline genetic testing, we usually talk about a rule of 3, like in Scandinavia, that you should have at least 3 cases of melanoma in at least 2 different individuals, or it could be the combination of melanoma and pancreatic cancer cases. When considering testing in a family with no affected persons available, we could also offer testing in some cases to those with a high NIVA count or but that depends from department to department and country to country.
Nei, det har ikke noe. Da kommer neste mann. Ja, vi har aldri blitt filmet så mye, så det her du, Henrik.
I protect myself always more than I did before. I maybe don't go out in 12. Also, when the sun is strongest, but I'm out all day.
Vi må jo gå ut når vi har sol her. Vi har ikke så mye sol her i området. Det regner mer.
We are seldom sun, so we have to go out.
I do nothing. No cream, but no, I use cream every day, you can say, when you're out in the sun.
Avoid the sun when it's strongest. Use sun protection, and you should obviously avoid smoking, because we know that the other kinds of cancer, like pancreatic cancer, but also the mentioned lung cancer, we know that occurs mainly in people with these variants who also were smokers.
Yeah, no, it's not healthy, but I stopped smoking for a year, but then I couldn't stay still, so yeah.
But I just quit in August last year.
I've seen every melanoma patient or mole patient in our clinic. We always teach sun avoidance, and I always explain to them that the risk, the main risk is the genetics, and therefore we need to see them anyway.
I think the following up with the dermatologist is very important, because they screen your body 2 times, 1 time a year, and they can discover it in the early stage. But what we can do ourselves is stay away from the sun from 11 to 2, use sun lotion, and also watch your body. Look at the moles, get your the one you live with to check, take pictures, see if they change.
the start that I get about 30, also 4 times a year, but now I 2 times a year. So they check all the body, so you can't remind what was for 2 months ago. So
Me and my father, we have lots of them. Birgit and Frank, they don't have so many. I think it's easier to, is that right?
Mm-hmm.
Yeah.
It's easier to follow.
Yeah, because you don't have this many. I have much. You do have much. Yeah, Axel actually has some of it also. Mm.
I would say that many patients who are mutation carriers tend to have lots of moles, but not everybody. It varies a bit, I think. But people with a lot of moles who find it difficult to do self-examinations will have the opportunity to get more often to our clinic. When people arrive with the suspicious genetics or the confirmed genetics, we always take the photographs. And it includes the macroscopic photograph of the whole skin with the moles and everything from every angle, and it's more like a fixed procedure.
Ja, ser veldig fredelig ut, men vi kan jo ta et nytt bilde av han hvis ikke vi har.
Ja, for det var bare sikkert, kan godt hende det var vinterhuden. Jeg har glemt å smøre meg i dag som vanlig, men at det kan være vinterhuden som gjorde at han
begynte å...
begynte å...
Ja, det kan være litt flassete, ja, for det ser kanskje litt tørt ut på toppen her, men det er ikke mye det altså, men... Jeg er ikke sikker jeg hadde gjort det hvis ikke den var her.
Neida, men det er helt greit.
Do you feel anything?
Ja, litt. Tusen.
No, it's a fast and simple procedure when you remove the moles when they're really small, because you can use this circular knife. And we usually remove like once or twice a year in Elizabeth, and I think that's the main reason that she doesn't have any melanoma the last 10 years. Because we remove the small moles when they're changing a little bit, just small changes, and then we just remove it as quick as this.
But I actually removed from my scalp, from my neck, arms, stomach, breast, thighs, legs, back, everywhere.
Patients in their 20s, for instance, we see like once a year. And then we tell them to take contact if it's any new moles that they are not expecting, or if it's any changes, or anything that they want to discuss. So they have this really open line, but we see them once a year most of the time. And then you have the patients in their 30s and 40s, and even who still had no melanomas. Usually we see them twice a year. And we do the total body mapping, and we do the total surveillance and talk to them. And then you have the patients who already experience one or more melanomas. And then it's more like on an individual basis. Some of them goes as often as every 3rd month, twice a year some, and we always have this open line that they may make a phone call whenever it's suitable.
I think so. I think it is every 6 months.
Yeah, I think so.
I am too. Yeah.
Yeah.
1, 2, 2,
Yeah.
4, 2.
0.
Så det får oppi det tidlig også. Får det tidlig, så satt det fullt på marken.
I thought a lot about it in the years when I had 4, right? Yeah. But now it's much better. But it's kind of when I'm finished with a dermatologist, the shoulders get a little bit down, and now it's another period of not thinking. That's for me. I don't know if it's that for you, but
it's the same for me.
It's the same here.
Same, yeah.
I think about it. I do that, but I don't want to concern myself all the time. But of course, you think about it sometimes. I like to be out, and I like to, yeah.
I'm also in a pilot study for pancreatic cancer, where we do a MRI and take blood samples once in a year.
Regarding children of known carriers, we usually do not do any routine examinations. Sometimes the parents ask us to look at specific moles in the children, and of course we do, but we do not include them in the routine surveillance program.
Like every night when we are in the bathroom, they are brushing their teeth, and I know my eyes just. I just look. It's not just it's normal. Yeah, it's automatic. Yeah.
Melanoma very rarely occur before the age of 16 or 18 or even 20. So there's no high risk in childhood.
The most important thing is to prevent patients from getting melanoma. So we come in the last line and give expensive treatment, and we can do some good, but the best thing would be to prevent the melanoma from occurring, or early diagnosis so that we can pick it out, remove it, and the patients do not have the need of any systemic treatment or all the things that we do. That's the most important thing, is if we want to do something about the mortality rate of melanoma.
Well, the people that comply with the surveillance program in our department, I have never seen invasive melanoma with thickness more than like 1.5 millimeters, I think. And we have never had any with metastatic disease or who have died from melanoma.
Men ellers så har jeg fått et litt annet forhold til ordet kreft da. Og vi har hatt litt forskjellig i familien. Så det går bra. Heldigvis. Vi har jo respekt for det. Har jo veldig respekt for det, men vi skal jo leve og ta vare på familien også, ikke sant? Det som vi har. Og den stor begynner å bli. Ja.
I'm careful with the sun. I use sun lotion. I don't smoke. But other than that, I actually live like I do. I don't take any more precautions because I need to live.